The broadcast is now starting. All attendees are in listen-only mode.
That was Michael Bolton, and that was also one of my favorite songs that I play often on my opening webinars, Go the Distance. I think that's particularly appropriate for medical students because they have a long distance to go, and sometimes it gets very, very stressful, financially, emotionally, psychologically. Okay, so that's what's going to start us out today. And today, actually, is Tuesday. It is October 26th. It's 9 o'clock in the morning here in the Chicago area. And this is going to be our second discussion on hemodynamic disorders, or HEMO2. It's our 7th webinar of the year, and we're going to do about 50 or 60, I think. And these are all the little notes I made for myself and some of the things I modified and read in terms of what we'll be talking about today. Let's see, did I have anything else to say? Also, I wanted to remind you that this is our first real topic that what you would call clinical. A lot of the stuff we had in our opening chapters were very much cell biology and basically just scientifically oriented. This is going to get more and more clinical. And it's also one of the longest topics, which is why this is part 2 already. When we were in part 1, I'm going to close this guy off. When we were in part 1, we talked a lot about the basic concepts of coagulation. Now, I know you're thinking, well, we learned about coagulation and physiology. There's a lot of basic science that you theoretically learned last year. But I think the one that should really have been gone into in much greater detail was the concept and all of the factors involved in coagulation. Because, I think that probably when your patients die, whether they die acutely or suddenly, there's probably going to be something amiss in their coagulation system. So we spent a lot of time talking about the basic coagulation tests and the famous tree of the coagulation cascade, the intrinsic pathway and the tissue factor pathway, and we talked about different factors and stuff. Now we're going to actually get into the kind of the clinical things, or the concept of thrombosis, the end stage, let's say, of the coagulation cascade. We'll be talking about how it comes about. To a certain degree, we already have. We're going to talk about the factors. I could probably list about 7 or 8 factors that are involved in thrombosis, but they're probably all related to these 3. Endothelial injury, like we talked about last webinar, alterations in blood flow, hypercoagulability disorders, primary and secondary, or genetic and acquired, known as Virchow's triangle, because that guy over 100 years ago basically understood these principles, and everything we've learned since then, I think, somehow relate to it. We'll be showing you the pictures of blood clots grossly microscopically, or thrombi, and I guess you could say a thrombus and a blood clot are pretty much the same term. We'll talk about the fate of them, what happens to them, a lot of the clinical correlations. We'll talk about not only the venous thrombi, which are the more common, but the arterial thrombi, and even the mural thrombi, the thrombi that occur in one of the walls of the heart, or the aorta. So there we go. There's Virchow's triangle. Famous Rudolf Virchow said that things clot, or thrombi form, when there is some type of injury to the endothelium, and we've saw many different kinds of ways endothelium can be injured, or what you might call activated, to start the whole process of both primary and secondary coagulation. Abnormal flow. If the endothelium is not sitting next to normal, smooth flow, but it's abnormal flow, or non-flow, in other words, stasis, or flow that is not smooth but turbulent, which we might call non-laminar flow. This is another edge to the triangle. And of course, people may be born with certain genetic defects of factors or factor inhibitors, which might result in primary hypercoagulation disorders. And there's a pretty good size list of things that hypercoagulation is associated with, and it may not be quite as clearly understood as the primary ones. Okay, so here we go. Endothelial injury. Remember last week we said that if the endothelium is injured, it takes a normal cell, which is often not easily even seen on light microscopy, very flat, thin cell lining the interface of all the different blood vessels of the body. It takes this cell, which normally protects against thrombosis, against coagulation, and it turns it on into something that is now promoting coagulation and promoting thrombosis. That's why we talked about the Jekyll and Hyde concept. Endothelium at rest, doing its normal job with normal flow and normal factors, is your greatest guard against thrombosis or clotting or coagulation. When it is disrupted by a wide variety of factors, flow factors, infectious diseases, coagulation disorders, then it becomes the opposite. That's why I have always thought of the endothelium as being the Jekyll and Hyde cell. Okay, so when endothelium is doing its job normally, it has several anti-platelet properties. Well, the first one is obvious, that endothelium is a barrier. It's an anatomic physical barrier separating the platelets from the subendothelial collagen or subendothelial extracellular matrix, okay? Endothelium also degrades ADP. And if you remember, ADP was one of the things in the granules of the platelets, the dense granules, the delta granules, which were one of the primary stimulators of aggregation. So endothelium itself degrades ADP. That's another antiplatelet property. Endothelium makes heparin-like molecules. And you know, heparin is an anticoagulant. Okay, it also makes a very famous substance called thrombomodulin. And thrombomodulin is the precursor or initiator of protein C, and protein C and its products are one of the main group of substances which regulate or inhibit the coagulation cascade at multiple levels. Okay, endothelium also makes tissue factor. Okay, and you know, tissue factor is the most powerful initiator of the so-called extrinsic arm of the coagulation cascade. Last but not least, if there is some fibrin that is made, the endothelium degrades it. Okay, it has fibrinolytic properties as well. So I can't think of any other substance or cell, let's say, which guards against unnecessary, abnormal, pathologic coagulation. Now, when it's activated, it does absolutely the opposite of what it did before it was activated. That's why all of a sudden it turns into a monster, okay? It makes von Willebrand's factor. And von Willebrand's factor is a substance which actually connects or helps to bind the platelets beyond the endothelial barrier directly into the subendocardial connective tissue, the collagen, okay? Now with platelets, endothelium also makes tissue factor. And if there was one substance which you have to say was the most powerful initiator of coagulation that gets the whole ball rolling and gets it rolling pretty fast, it's tissue factor. Now, here's another really cool thing that it does. If you remember, plasminogen, which we probably mentioned briefly, is actually a control, or it inhibits the coagulation cascade? Well, guess what? The endothelium inhibits the inhibitor. How do you like that? So an aggravated endothelium, disrupted endothelium, activated endothelium is one of the greatest things to promote thrombosis. Has all these prothrombotic properties. Okay, that was the first angle of Virchow's triangle. And let's go into the second angle now. Abnormal flow. Now, if you were a physicist and you were studying flow phenomenon, you would draw these little vectors. And these vectors would be relatively straight and smooth and parallel. That means the fluid inside this vessel are all moving in one direction, and it is along the axis of the vessel. But there could be substances or phenomenon which cause flow to be turbulent. You know, perhaps some disruption of flow, perhaps a partial obstruction, perhaps a vessel or a chamber of the heart not contracting properly, and therefore the flow in that chamber is non-smooth, or what we call turbulent. Turbulent flow does not have smooth currents. It has eddies. Okay, eddies are like a little whirlpool. Rather than things flowing smoothly, they flow in kind of a haphazard zigzag way. Also stasis. If you had no flow or greatly diminished flow, or something we call stasis, okay, something that's disrupted or slowed or stopped or blocked, then that in itself, just the stasis of flow, would also activate the endothelium or disrupt it, okay? And all of these factors that we just talked about, non-laminar flow, eddy, stasis, these are all things which, when the endothelium is now disrupted or activated, would then tend to bring the platelets into contact with the substance beyond the endothelium. In other words, the extracellular matrix, or I put down extracellular fluid, but I think we could just as easily say extracellular matrix. I think that's a better way of saying it. Whoops. Let's put a C in there. Okay. The third leg, the third angle of Virchow's triangle, and final one, is the substance or the concept of hypercoagulability. Why would blood coagulate without even being triggered up very nicely? What could be wrong? Well, the one thing that could be wrong is that there were some mutations of the genes involved in not only the clotting factors, but the inhibitors of coagulation as well. Now, statistically, there's a pretty good sized list of what we would call primary or genetic hypercoagulability disorders. That means you're born with it. That means it's due to a genetic mutation. And probably the most common one is something called the factor V, or more commonly, the factor V Leiden deficiency. Or you could say the factor V Leiden mutation. But factor V Leiden deficiency is a situation in which a gene, okay, which is very appropriately called F5, is mutated or absent, and therefore factor V is made in an abnormal way. Now, I know what you're thinking. You're thinking, whoa, wait a minute. If factor V doesn't work, wouldn't that inhibit coagulation rather than make it more sensitive? Technically, yes, but don't forget, factor V is then mutated in such a way, even though it's an indirect way, such that it now becomes hypercoagulable. It accelerates the coagulation cascade rather than inhibits it by virtue of not being there. There's also a few various defects in the genes that code for prothrombin. And like factor 5, if you have a prothrombin gene defect and therefore abnormal prothrombin, that doesn't mean that coagulation is going to be inhibited because prothrombin is abnormal, let's say. In this case, it actually accelerates it. So these are hypercoagulability genetic defects, factor 5 latent. Now, the other concepts are even more easy to understand because, we have a homeostasis between coagulation, which is the formation of fibrin, the formation of a blood clot, and all of the complex factors like protein C, protein S, antithrombin, which inhibit the coagulation cascade. So your body is in a constant homeostatic balance between the production of fibrin and the inhibition or the dissolution of it, okay? Now, what would happen if there were genetic defects that made antithrombin defective or absent? Then one of the greatest controllers to coagulation would be absent. And that would be a very easy way to understand hypercoagulability on a genetic basis. Also, protein C is a substance which by itself and its action on another inhibitory protein, protein S, what would happen if you didn't have those because of a genetic defect or a mutation, let's say? Well, that's another example. These are pretty rare. Now, even more rare than that, there is this concept of the cascade that dissolves or lyses the fibrin. And any technical defect in the proteins involved in fibrolysis, which means that delicate balance between the production of fibrin and the disappearance or digestion or lysis of it is upset, and therefore you're going to have hypercoagulation because the inhibitors are inhibited. So here, the factors are inhibited, and in the bottom, the inhibitors to the factors are inhibited. And I think they should both make sense, I hope. Okay, we saw this again. We'll probably see it again now. And I told you that this coagulation chart is something that you're going to see in one way, shape, or form for the rest of your life. Every time a salesman comes to your office and tries to sell you some new anticoagulant, or you go to conferences on thrombosis. Anyway, as you know, because I've already told you a couple times, there's an intrinsic as well as an extrinsic pathway to coagulation. Talk about two arms, let's say. We know that the DNR prothrombin time measures 1, and the partial thromboplastin time, which is here, measures the other. The intrinsic pathway starts off with the conversion of factor 12, which is inactive, into an active enzyme, factor 12A. The A stands for active. And then A converts 11 to 11A, okay? This is the cascade of changing inactive proenzymes into the active enzymes. Then the active enzymes, like activated factor 9, then can convert with factor 8, factor 10, inactivated into activated, which now we're kind of like at the end of the cascade because factor 10 activated, then converts prothrombin to thrombin, okay? And then finally, thrombin is the main and last thing converting fibrinogen, to fibrin. And then, of course, if you think it's over, you can, because this was a long trip we just took. But then there's a whole wide variety of factors which can either strengthen that fibrin clot or dissolve it. And remember, all the dissolving factors is called fibrinolysins. Now, on the other hand, in red, we have substances like protein C with the action of protein S now activating that, doing a control on the coagulation cascade. So rather than this thing forming the blood clot, ultimately it would inhibit the formation of fibrin. And protein C acts on both factor 5 and factor 8. And then there's a substance called antithrombin or antithrombin 3, which is inhibitory on the production of thrombin, and that's why it's called antithrombin. And it also has an effect on inhibiting factor 10 going to factor 10A. So this is probably the best scheme again, and I review it and sometimes I change it a little bit over and over. But if you wanted to define hypercoagulability now, based on your understanding of all of the different factors in the cascades, the intrinsic and extrinsic, ultimately forming fibrin, the best way to understand hypercoagulability is anything which accelerates the cascade or inhibits the inhibitors. Okay, and that we're talking about hypercoagulability, technically whether it's primary, which is genetic, or secondary, which is acquired or associated with other diseases. So here's the acquired diseases now, and they're not quite as easily understood as the genetic diseases, in which we have the names of specific genes with actions on specific factors or factor inhibitors. Somebody at bed rest for a long time, which might be perhaps most of your hospitalized patients, have a tendency to coagulate, okay? Oh, you could talk about biochemical reasons and all that, but think about it. If you're laying in bed, you're not moving around very much, and that means your veins are not pumping very much, especially the large, deep veins in your lower extremities. Same thing with myocardial infarct. What might you have with the myocardial infarct? Well, inactivity, perhaps stasis. These are all things that you have to watch out for as being hypercoagulability. In other words, formation of clots. Atrial fibrillation is a really interesting concept. Atrial fibrillation is not only a cause of hypercoagulability, but it's an effect of it. Why would atrial fibrillation cause hypercoagulability? Because when the atria do not contract smoothly and they just twitter or vibrate or fibrillate, so to speak, we are now introducing non-laminar flow with eddies. And that is a reason why a clot can very easily form. Okay, on the other hand, why might it be an effect? Well, if you are hypercoagulating blood, one of the places you might form a blood clot is in your atria, and that might result in itself as atrial fibrillation due to wall damage and the presence anatomically of a clot. Tissue damage, surgery, fractures, trauma, burns. These are all things which are associated with increased likelihood of coagulation, perhaps not as clearly understood as some of the others. There's a syndrome that cancer patients have. It started out with cancer of the pancreas. Then it was noticed in a lot of the GI cancers or adenocarcinomas in general, a syndrome called Trousseau syndrome. I guess another way you could name it is migratory thrombosis, because people with cancer, especially GI cancers, especially pancreas cancer, produce a substance, okay, which actually accelerates or increases the likelihood of the formation of clots. Another name for Trousseau syndrome with cancer patient is migratory thrombophlebitis, because it may occur in one place and then it may occur later on in another place. That's why they call it migratory. Prosthetic cardiac valves are damaging to cells that could set up the initiation of thrombosis as well. Something we're going to be talking about at length in many areas of this course is DIC, or disseminated intravascular coagulation, and that's why it's called DIC. It's often almost synonymous with the word shock, but it's two different technical pathophysiologies. DIC can cause hypercoagulation, or it could be an effect of it. Okay? What is DIC? That's exactly what we said it was. It's disseminated small blood vessel coagulation associated with shock and a few other things, some cancers, some obstetrical procedures that are very, very difficult. Heparin-induced thrombocytopenia. Okay, well, why would a thrombocytopenia produce hypercoagulability? Isn't that a paradox? Well, the fact is, even though it is related to heparin and it is a decrease in platelets, these patients have a tendency towards hypercoagulability. And let me ask you a question, especially when we were just talking about DIC. What would happen if you had massive coagulation or blood clots being formed all over your body? What would happen to the platelets? Well, they would decrease because they're being used up, they're being consumed. It's one of the consumable clotting factors, with a few other ones as well, like factor VIII, and I could probably rattle off 3 or 4 more on a good day. People with lupus, the systemic autoimmune disease, often produce a substance called the antiphospholipid antibody syndrome. Well, if you have antiphospholipids, but you have an antibody against it because you have an autoimmune disease like lupus is the best example, this substance can then produce an anticoagulant-like effect. Okay? Here are things that I think that are very, very common, but not always easily understood. Patients with cardiomyopathies, patients with nephrotic syndrome, massive loss of their blood proteins, okay, edema, people in hyperestrogenic states, of which pregnancy is one, oral contraceptives is another one, excessive high estrogen levels are associated with blood clots. That's why women want to know if they take birth control pills or if they take hormone replacement, are they going to get blood clots? In some cases, you have to warn them that they can. Sickle cell anemia, smoking, obesity. So here we go. If you take a smoker that's obese and doesn't get around very much, that in itself has 3 factors for having a hypercoagulable blood in an acquired manner, not in the primary or genetic manner. Well, blood clots. You may not have seen as many as the pathologists do. You may have seen radiologic evidence. You may have seen vascular studies. But a blood clot, when it's formed, adheres to the blood vessel wall. If that blood vessel is a heart wall, like an atrium or a ventricle, you call it a mural thrombus. Okay? If it occludes or adheres to an artery, it could cause an occlusive clot, thrombosis, and result in making the tissue that it feeds die, which is called an infarct. Okay? If you have a blood clot inside of a vein, it is generally going to propagate and perhaps even split off or embolize going towards the heart. And if you have a blood clot in an artery and it grows or splits off, it'll generally go in the opposite direction, away from the heart, simply because when clots break off, they go with the flow. The blood clot can completely obstruct the vessel, or it could just partially obstruct the vessel, or it might not obstruct it very much. It just may be producing a little bump. But then what does that little bump do? It screws up the blood flow, and it makes the flow non-smooth, non-laminar, eddies. So even if a blood clot is non-obstructive, it may disrupt the flow without obstructing it, and therefore add to the damage to the endothelium. Grossly, you've seen blood clots. They're red, recent blood. But like the changes we saw in anything, if this blood clot, what they call organizes, and now you have an ingrowth of macrophages chewing up junk and blood vessels, they may look yellow after a while. So the change from red to yellow is not too quick. It's not days. It could be a week. It could be more than a couple days. And of course, like the end stage of this healing or the follow-up of the inflammatory process, the blood clot then, with the deposition of more fibroblasts and more collagen, becomes more like a scar and become gray or white. So the evolution of a blood clot basically would be red, yellow, gray, white. And that would correspond in time to whether that blood clot was very acute, perhaps days, to organizing, to perhaps a few days up to a week or two, to old, now where we have the white collagen, causing it to occur perhaps weeks or maybe even months after its formation. However, one thing it can also do is completely resolve too. So we'll be talking about the fate of thrombi. Here's a blood clot. You know this is a septum, a ventricular septum. You know this is the right ventricle because it's only about a third as thick as the left ventricle. And in the left ventricle, besides having a hole, which it should have, a lumen, we have some sort of tissue that doesn't look like it's just sitting there. So, and if you were to try to remove that piece of tissue, it might be difficult. In other words, it adheres. So I would say, what is the difference between a real blood clot that formed before the patient died versus pooling of blood, which you may have seen in your autopsy dissections last year, that doesn't adhere. So adherence is a concept that separates the premortem from the postmortem blood clots. Here is an aorta. I think you could see some kidneys over here. And I'm guessing this is probably below the level of the renal arteries here. And you can see not only is it dilated, it may be aneurysmal, but it also is basically obstructed mostly by a large amount of tissue, and that's a blood clot. Now, I know what you're thinking. You're thinking, well, why can't that just be bad atherosclerosis? Well, bad, severe, prolonged atherosclerosis is basically one of the things that will disrupt blood flow and cause a clot to form. So we're going to be dealing at length with this concept of atherosclerosis, and we're going to be dealing with the concept, like we are today, of thrombosis. And basically, they are very, very intimately related to each other. Non-atherosclerotic blood vessels, whether they're arteries or aorta, they generally are protected from blood clots. Plaques, however, especially plaques that are advanced or ulcerated, they would be a predispose or as a trigger for thrombosis. So here's all the things, and I think they're logical, that thrombi can do. Well, they could get bigger. They could propagate. And when they get bigger, they basically grow downstream. In other words, towards the flow, okay? They could break off and flow downstream, whether they're arterial or venous. They could completely dissolve by normal substances or processes which dissolve fibrin and blood clots, so-called fibrinolytic mechanisms, which we talked about earlier. Or they could become organized. Remember, organization, or the ingrowth of blood vessels, ultimately resulting in the ingrowth of not only endothelial cells and blood vessels, but also fibroblasts and collagen. That's another possibility. And if they are obstructive or perhaps almost obstructive, they could then develop another lumen, Lumen, within their substance and what they call recanalization. So you might say, oh my God, there's a blood clot and it has occluded this vein or this artery. But if you examine it or look at it or do vascular radiologic studies or look at it microscopically, there are lumen where blood can flow within the blood clot. So here's what I just said, only it's graphic. There's a thrombus. Happens to be an iliac vein. What can happen to that thrombus? Well, ideally, hopefully, perhaps even most commonly, ultimately, it could completely dissolve by fibrinolysis mechanism. You have a normal vein again. Another thing that it could do is break off. And think about it. If this big vein breaks off a fragment, it has to go with the flow. And it has to wind up, anatomically speaking, ultimately lodging in the lungs, okay, passing the right side of the heart. It could actually form little lumen that are endothelial lined within the blood clot, and that's called recanalization, and I think it's a good word. Or it could become organized and more adherent and incorporate into the wall of the vessel. Okay, and if this came from this, you would say it's largely resolved, but part of it has thickened the wall of that vessel. Okay, and think about it. Anatomically speaking, we said that a venous blood clot, when it fragments or embolizes, goes towards the propagation towards the heart. Okay, because that's the only way it can go. Okay, if it goes with the flow. But when it gets bigger or it grows, it also propagates towards the heart. I've had a few arguments with people about this. Some people felt that when a thrombus grows, it grows away from the heart. But no, it grows in the same direction that it embolizes. And that's with the flow towards the heart. And that's also the opposite of true, of course, with arteries. What's this? Well, I think if you look carefully, you might say, well, it might be a blood vessel, but, there's no hole, there's no lumen. But you can see a pretty thick wall of smooth muscle cells, so you're probably thinking, okay, well, this looks like an artery, and this looks like an artery that was maybe thrombosed. And here, you probably know it's an artery, because not only do you have those spindly smooth muscle cells and an occluded lumen, but you can actually do a stain, an elastic stain, which stains the internal elastic lamina of a blood vessel. And basically, this is an occlusive arterial thrombus. Is there something funny about these two pictures? You're thinking, well, wait a minute. We got a couple of arteries here and they're thrombosed, but I don't see any atherosclerosis. So you might ask yourself, this thrombus may have occurred in an artery, even though it's not a large artery, it's a relatively small artery, without the presence of previously existing atherosclerosis. In reality, in the arteries which atherosclerosis involves, the bigger arteries, the aorta, almost certainly if you saw an occlusive thrombus or any thrombus, it's probably going to be associated with little calcified flecks or clefts of cholesterol that are existing also. So what do we want to learn from this is that even though thrombi are often associated with atherosclerosis or damaged arteries, here we have a thrombosis that are occluded, and there's no atherosclerosis. Okay, so what is the most common clinical setting for a thrombosis? A thrombosis that could even be potentially fatal, and that's called DVT. It's the deep veins. That's what the D stands for. And the V stands for venous, the deep veins of the pelvis and lower extremities is where most of the clinically significant and even potentially fatal emboli come from. So the calf, the thigh, the pelvis, venous thrombosis. And remember, it has to be deep. A superficial thrombosis in that area is probably not going to be as clinically important or as serious as a deep vein thrombosis. Well, patient with congestive heart failure now has increased pressure in those veins, stasis of flow, okay, perhaps physical inactivity as well. So we got the setting here as CHF being a big factor. Inactivity, of course, is probably just as much of a factor. And I think it's probably a good thing to understand that any patient that you have that happens to be inactive, bedridden for a long time is at risk, whether they have surgery or not. And of course, trauma to the veins would be a nice factor. Perhaps a hypercoagulable disorder, surgery, burns, injuries to blood vessels, and procoagulant substances from tissues. Okay, tissues can break down, and there's a family of compounds which promote coagulation. Now, here's the one that I think you should also understand. Okay, this is something called tissue plasma activator, okay? It's a polypeptide or a protein. And you should think as TPA activity, or activity which inhibits coagulation, always being in constant homeostasis with coagulation in itself. So you should not think of coagulation as, something that occurs if this and this and this is present. You should think of coagulation as a process which potentially is occurring or could occur all the time. But there is tissue plasma activation, which actually inhibits coagulation. So if the inhibitor is reduced for any reason, the normal homeostasis is then shifted towards the formation of blood clots or thrombosis. Okay, these are the factors, the pathophysiology of deep vein thrombosis. A thrombus can be arterial, not just venous. Probably the most likely place for an arterial, clinically significant thrombus would be in the aorta or one of the chambers of the heart, like a left ventricle, left atrium. Technically, that would be the arterial cardiac thrombi. If you have a mural thrombus in a heart, it could embolize and travel downstream. And if it theoretically was in a right atrium or right ventricle, downstream would be lungs, wouldn't it? And if it was in the left atrium or left ventricle, downstream would be systemic, aorta in all its branches. Now, when they talk about thrombi going to different organs, like brain, kidneys, I should have probably said emboli rather than thrombi. Spleen, lower extremities. They'll often say, emboli to the kidneys occur, 20% of the time, or spleen 15, or, brain 25. You shouldn't really take those percentages too seriously. Because if you just remember from your normal physiology that these different organs normally get a certain percentage of the cardiac output, it would be logical to think that if anything came from the heart, any thrombi embolizing to these areas, it would be the same percentage of the time that is correlated with the percentage of blood flow that that organ gets. Okay, I don't know if I made that unnecessarily complicated or not, but the lodging of an arterial embolism from an arterial thrombus is directly proportional to the percentage of the cardiac output that that organ or area happens to receive. Let's see if we want to say a few other things before our break. Yeah, I think I want to say this before we take our break. We'll talk about atheroemboli. Remember, so far we have been talking about blood clots and the fact that they could embolize and propagate downstream. And if it was arterial, it would be away from the heart. If it was venous, it would be towards the heart and the lungs. Okay. What are these little white clefts over here? I think I could convince you that this is a small blood vessel. I think if we did an elastic stain or just looked at the smooth muscle, you could say it's an arteriole. So if you have now an arteriole that has an obstruction, could that be a primary thrombosis? Yeah, it could be. But could it also be an embolism? Okay. Now, if it was an embolism from a thrombus higher up in the arterial tree, it might also contain little flecks of cholesterol as well. So that solves our big mystery. When you see a thrombus or an occlusion in an arteriole, and remember, the small arterioles themselves are not classically part of atherosclerosis. That's the larger arteries, isn't it? So when you see a part of a calcified or cholesterol crystal or cleft inside of an arteriole, you can probably theorize with a high degree of likelihood that this came from higher up. So this would be the question I might ask you on an exam. I will give to you the possibility or the fact that this is a thrombosed arteriole. And I'm going to say, did this come from an embolism, arterial embolism, or did it originate here? Well, because you don't normally have these big cholesterol clefts in the small vessels, you can say this is most likely an atheroemboli coming from higher up. And this, I hope that was logical. So you know what, we're doing pretty well. How about if we take about a 10-minute music break, and I'll put the camera on our clock and little lights and everything, and we'll see you in about 10 minutes. And I picked out 3 nice little additional songs during our music 10-minute break. Whoops, let's try that again.
and I, in awesome wonder, consider all the worlds thy hands have made. I see the stars, I hear the rolling thunder, thy power throughout the universe displayed. Then sings my soul, my Savior God, to thee. How great thou art, how great thou art. Then sings my soul, my Savior God, to thee. How great thou art, how great thou art. When Christ shall come with shouts of acclamation and take me home, what joy shall fill my heart. Then I shall bow in humble adoration, and there proclaim, my God, how great thou art. Then sings my soul, my Savior God, to thee. How great thou art, how great thou art. Then sings my soul, my Savior God, to thee. How great thou art, how great thou art, how great thou art, how great thou art.
Well, I hope you enjoyed our music. Two of those songs were very spiritual. I don't normally play too many spiritual songs, but I love country and western. So having Randy Travis do my favorite spiritual song actually choked me up a little bit. When I was in the hospital a few months ago when I almost died, I played this song a lot, and it reminded me of basically being rescued or saved from death by a wide variety of factors. And to tell you the truth, I think that one of the biggest factors is that I still had a job to do, so I was not ready to go yet. And I'm doing my job right now, so I'm very happy. But I will have to tell you, every time I hear that song, I'm sorry, there are certain songs that make people cry. Every time I heard that song, I actually do cry. So let's stop crying and talk about coagulation again. I got some final interesting topics coming up. And here we go. We're pretty close to something. Yeah, here we go. This is a very, very special type of coagulation. It's very special and it's very common. In fact, I might even go as far as to say is that your patients that die, not necessarily suddenly, but perhaps of advanced malignancies or shock due to a variety of reasons we'll be talking about, will die of DIC. And DIC is exactly what I have told you it is. It's disseminated intravascular coagulation. It means that the blood in your entire body, even the small vessels, even the capillaries, is coagulating. And there's a statistical associations and a lot of causes or pathophysiologic associations, probably patients that are at high risk for DIC are obstetric complications, okay? Very, very difficult deliveries. When it's rare, but when a mother dies during delivery, it's very possible or probable that DIC entered the picture. People with advanced cancers, which is in this country probably about half of everybody that dies, frequently have DIC. There's a wide variety of tumors that are associated with this, but the one that's the most highly associated is a type of leukemia called acute promyelocytic leukemia, which has a very, very high association with DIC. Now, if you want to know the most common cause, it's going to probably sound like almost everybody that you know that ever died, and that's shock. We'll be talking about shock, but one thing that happens in shock, in fact, not one thing, but probably the main thing, is a circulatory collapse. And if your blood isn't flowing, doesn't that activate endothelial cells diffusely? Okay, so very often the term shock and DIC are almost used interchangeably, but one is circulatory collapse. The circulatory collapse then triggering the activation of the endothelial cells, which forms with blood clots forming all over the body. Now, this type of coagulation is called a consumptive coagulopathy, which means in the process of the coagulation, we are consuming platelets, we are consuming fibrinogen to be part of that blood clot, we are consuming factor VIII. And look, I even made a little list here of so-called other so-called consumable clotting factors like factor V and factor XIII. These are also things that are consumed during clotting. Most of the other factors are not consumed, okay? So think about it. If you have a diffuse coagulative process and your platelets are being consumed, you don't have any more platelets left, what's going to happen? You're going to have bleeding, aren't you? So even though these patients are coagulating diffusely, they are also bleeding. Okay, they may require many, many units of blood because they don't have any platelets. So it's a very, very, very horrible situation, has a high mortality, and very often basically has about the same mortality as shock itself, which is often, pre-fatal. Here, take a look at this kidney, okay? You could probably recognize a glomerulus. You probably recognize tubules. I don't think I have to go into that. Look, but do you see that inside these glomeruli you have vessels? But the stuff inside the vessels is a little bit redder and maybe a little more granular than regular blood. Okay, this is fibrin. This is a kidney that is filled with fibrin. Why? Because the capillaries are showing a diffuse coagulation. This is DIC, and it's evident in the kidneys. And if you don't believe me, as you know, we have stains here, which can actually stain fairly specifically for fibrin. And now you know this is not just congested blood, but this is actually the coagulation final product of fibrin. Okay? What about significant emboli? What about pulmonary embolisms? You know, probably one of the most common causes of death in people that are immobilized. Perhaps not as high as it used to be, but still a very, very leading cause of death as a terminal event. Now, an embolism technically can be systemic, you know, coming from the left side of the heart, and mural thrombi is usually the reason, but also from aneurysms or in the aorta is also possible. So just to make it very simple, when a person flips, often they use that word, when a person throws or embolizes a systemic embolism from a systemic blood clot, most of the time it's from the heart, or mural thrombus, and about 20% of the time it's from the aorta. Okay? Of course, a venous embolism, by definition, has to go to the lung, doesn't it? Well, 99% of the time. But there's something called the paradoxical embolism, where the blood clot goes to the heart, and there's probably a shunt from the left to the right, or the right to the left. And if a right to left shunt exists, a venous embolism may also go systemic. But are blood clots the only thing that could embolize? No. Fat can embolize. Air can embolize. And amniotic fluid can embolize too. But let's talk about the usual, most common type of embolism, the pulmonary embolism. It might surprise you to know that most pulmonary emboli are silent. Most people don't believe that. But there have been a lot of studies of people that have been in prolonged bed rest, or, you know, sitting on airplanes for 48 hours and that, and they are just, you know, showering their lungs with emboli, and most of them don't even know it. But when they have chest pain, perhaps shortness of breath, suddenly, and a low PO2, those are the common three findings or symptoms, signs of a pulmonary embolism. These are the ones that are not silent, okay? Now, if the clot occludes more than half, and the reason why I'm saying more than half rather than half, technically the studies have shown that if you suddenly occlude 60%, that's a little more than half, of the pulmonary vasculature, then that embolism has a high risk for death. So when you see a blood clot that occludes more than half, that patient's probably dead. You're probably looking at it at autopsy, okay? Because all of a sudden you now are occluding that patient's right heart, and if the right heart has sudden failure, then ultimately the entire heart fails. The term saddle embolism is often used. In other words, if it's a blood clot is big enough to pass through the main pulmonary artery and then lodge or hanging over the bifurcation of the main pulmonary artery, in other words, the right and the left pulmonary artery, that's usually more than 60% of the total pulmonary arterial blood supply, and saddle emboli are usually fatal as well. Let's see, I wanted to say something about this. Oh yeah, the reason why I'm saying 60%, it's if only one lung is suddenly occluded with a blood clot, not one in part of another or both of them, very often those patients survive. In fact, they usually do. And when I did nuclear medicine, we sometimes saw people with pulmonary emboli that involved in an entire lung. And of course, they were probably symptomatic, but they survived. But more than 60% is usually fatal. Sometimes it's very important, especially from a medical legal point of view, or even, routine, so-called routine autopsies, is to determine whether the blood clot was formed before the patient died and therefore possibly what killed him, or if it just resulted from settled blood that formed after the patient died. Now, I bet you, if you are a second-year medical student and you've done anatomy and you dissected your cadavers, you probably saw a lot of blood clots that lodged or settled in very big areas like atria, ventricles, aortas, large veins, vena cava. And you're wondering if that patient had the blood clot, or maybe even if the blood clot killed them. So how do you know the difference between the two? Well, very simple. If a blood clot forms before the patient dies, and or possibly even kills the patient, it almost always adheres to the wall of the blood vessel, okay? Even if it's a loose adherence. Adherence is the big word that separates the premortem from the postmortem blood clots, okay? There's also something that is classically called the lines of Zahn. And if you remember when we talked about clots that can become organized and have like little lines of fibrin separated by cells, that's a proof that that blood clot has formed before the patient dies, if it has the lines of Zahn. If a blood clot forms just from settling or after the patient dies, then it does not only not adhere, but it has a amorphous or gooey consistency. Now, I don't know if you've ever saw chicken fat in your life, or if you ever saw jelly. Of course you saw jelly. Jelly doesn't have any substance to it. It's just gooey, and so is chicken fat. Here, maybe I got some pictures here. Yeah, that's chicken fat. That's jelly. It's kind of a thicker jelly, currant jelly. But here's a blood clot. You can see they're opening up a vein. This black thing is just something to hide the number or the name of the autopsy. And you can see there's a clot inside of it. And you might say, did this clot form before the patient died, and that's what killed him? Maybe. Or added to his death, or afterwards. Well, here's the thing. Now that you have your hemostat separating or opening up this blood vessel, you then grab it with your hand or your forceps or whatever, and if it adheres to this wall, it probably formed before. Now, microscopically, if you're still not sure, you take this clot and you see not only are there little infiltrates of cells forming these little lines of fibrin, what they call the lines of Zahn, then you know this is probably a recent blood clot, but it formed before the patient died. Okay, remember we talked about the saddle? Well, here's a main pulmonary artery. Now, I don't know if this is right lung or left, but you can see that this giant blood clot came through the main pulmonary artery, and then it decided to overlap over the bifurcation between the right and the left lung. So you know that's more than 60% of the pulmonary total vasculature. And you know it's premortem. And you know, of course, that it was fatal. So once again, the saddle emboli, usually more than 60%, usually fatal. But also remember, and I think you're going to forget this, so I'll tell you again, technically most pulmonary emboli are silent. I was kind of shocked to hear that, but it's the truth. Now, the systemic emboli don't come from the veins, they come from the artery. It could be due to the left side of the heart. It could be due to the aorta 20% of the time. But a systemic emboli can also come from the right side of the heart. Now, if you say, hey, that's anatomically impossible. Well, remember, the so-called paradoxical emboli, which I've seen only a couple times in my life, would be if something formed on the right side, but then it went to the left side because of some type of shunt, either at the aortic level or the atrial level or the ventricular level. So when we talk about congenital heart diseases, we'll be talking about hearts that have shunts. And some of those shunts can actually be higher pressure on the right side than on the left. And if that's the case, then that higher pressure is what moves a venous systemic embolism into a arterial systemic embolism. So, once again, we've said this before, we'll say it again, these systemic emboli will lodge directly in proportion into how much cardiac output that gets. Now, I haven't memorized the percentage of cardiac output that the brain gets or the kidneys get, but whatever that percentage is, that's going to be obviously the percentage of times that those systemic emboli are going to be involving those organs. Fat embolism, air embolism, remember we said blood clots are not the only emboli? Well, if you have a bone fracture, especially a very significant bone fracture, like a long bone crushing injury, the fat from the marrow can get into the venous sinuses and cause fat emboli. These might be very, very difficult to detect on autopsy, but sometimes you can if you're careful. You've probably heard of scuba divers getting something, the bends, or sometimes they call them the chokes, and it's basically air that has gone out of solution, and it's not entire air, it's usually mostly nitrogen and argon. The oxygen is very soluble gas, but nitrogen isn't. So a scuba diver that rises too quickly can have his dissolved nitrogen actually start to bubble off and form ultimately as an embolism, going where emboli normally go. Patients that have had a very difficult or prolonged delivery, remember we talked about that also being a factor with DIC, but an amniotic fluid in a very difficult delivery or prolonged can actually also get into the mother's uterine venous sinuses and cause amniotic fluid embolism. And these are very, very, very serious, okay? Maybe a small amount might happen on many deliveries, but if it's clinically significant, basically associated with a pretty high mortality. What is this? What if I told you this was a maternal lung of a woman that died during delivery? Well, what's that stuff inside of her pulmonary arterioles? They look like little flat, almost like squamoid cells. Well, they are squamoid cells, because if you remember, the surface of the amnion has these flat little, they call them squamous cells or squames, and they can also, in an amniotic fluid embolism, result in traveling into the mother's pulmonary arterial system as well. And now you're going to ask yourself, what is this? Well, it's fat. You can see at least half of it is fat. Some of it is cells. Some of them are big cells. Some of them are small cells. And if you are an experienced histopathologist, you can instantly say, this is bone marrow, okay? Okay, well, let's say it's normal bone marrow because it's half fat and half cells. But what if you saw the big picture and this bone marrow was inside of a blood vessel? Oh, it must be a fatty embolism. Now, what is funny about this fatty embolism? Remember I told you that most of the significant and even fatal fat emboli that either are fatal or add to the fatality of a disease, I told you they're mostly from the long bones, the arms and the legs. Well, long bone marrow is 100% fat. Fat that has a lot of cells, and is only about 50% fat, is not from the appendicular skeleton, but it's from the axial skeleton. So this could have been, rib or sternum or vertebral body. But anyway, this is a marrow or fat embolism. Well, what happens if a blood vessel, because of a clot, for any reason, or an embolism, occludes the blood supply to that area? Well, that's called an infarction. An infarction is dead tissue due to the loss of decreased blood flow, or therefore decreased oxygen, decreased nutrients, whatever. Make it easy for you. In most of the major infarctions that we see, the clinically significant ones, they could be divided into whether you call them a hemorrhagic infarction or an anemic infarction. And hemorrhage is red, so they talk about either red infarcts or white infarcts. Why would an infarct be red? Well, an infarct would be red is if it is deprived of blood, but there's also a secondary blood supply. Like the lungs. The lungs have a secondary blood supply. They have the pulmonary arteries and they have the bronchial circulation. So an infarct of the lung is usually red acutely. What about the liver? Well, the liver has a big portal circulation, which is about 80% of it, and they have a hepatic artery. So technically an infarct of a liver would be red as well. Now, if the organ that is infarcted does not have a dual blood circulation, but end arteries, like a kidney or a spleen, then of course an acute infarct there would be white, simply because there's no secondary, hemorrhage or secondary blood. Now think about it again. If it has end arteries, it'll be white. If it has no end arteries but a secondary circulation, it'll be red. So are you thinking all of a sudden infarcts of the lung and liver are red and infarcts of the spleen and kidney are white? You're absolutely right. But that dead tissue then evokes the inflammatory response, in which you have infiltrate of neutrophils, macrophages. It then goes through an organization phase with the ingrowth of new blood vessels, making it look red. And ultimately, it can also result in scarring then, in other words, making it look white. So an infarct that is white could be acute if it's an end artery organ, like a spleen or a kidney, or it could be white as if it's an old infarct, perhaps weeks or months, and most of that white is now due to fibrous tissue or collagen or scar. So the factors for infarctions, of course, are the nature of the blood supply. If the infarct develops slow, it's better for survival than if it develops fast, because if it develops slow, there's a good chance some collateral circulation has grown in there. And of course, certain cells that have an extremely high oxygen demand, like the muscle cells of your heart, the cardiac muscle cells, they're more vulnerable to hypoxia, or your brain cells is another good example, than a cell that does not have a high oxygen requirement, like a fibroblast. And of course, should go without saying that if a patient is in congestive heart failure, that's going to be very bad prognostically because of lack of good flow than a patient that is not in congestive heart failure. Here's a lung, and here's the pleural edge of a lung. That looks like it might be a major fissure there. And you could see it's kind of spongy here on the top, but on the bottom, it looks like it's more dense and more hemorrhagic. Okay, this is a spleen here, which has end arteries, so an acute infarct here could very easily be called a white infarct. So that's a a white infarct, that's a red or hemorrhagic infarct. Now, to make things even more complicated, pulmonary emboli, as a rule, do not cause infarcts, only in a small percentage of the time, like if there's severe congestive heart failure. Why? Because the lung has a dual circulation. So if the pulmonary artery has obstructed this portion of the lung, it still has a secondary bronchial circulation, doesn't it? But if the secondary bronchial circulation, like with congestive heart failure, is impaired, then yes, it will be hemorrhagic. There will be an infiltrate. So most pulmonary emboli, even the big, large, clinically significant ones, will not show up as a chest X-ray infiltrate, because whereas it's not perfusing, it's still ventilating. So that's what they call a VQ mismatch. Here's a kidney. You can see there's a cortex. And you can see there's kind of a big sort of triangular or wedge-shaped area that looks like it's kind of puckered down, what they call a wedge-shaped infarct. And this infarct basically corresponds to the area of a distribution of a pretty good sized artery. You know, there's about 5 or 6 or 7 segmental arteries in the kidney. Well, if you have an occlusion of one of them, it will show an infarct which corresponds to the region of distribution of that segmental artery. So here it is grossly, looking at it on the surface. I think I could convince you it's kind of wider towards the outside than it is towards the inside. Here it is when you cut the kidney, slice it, and here it is microscopically. The lack of cells, the lack of nuclei, the lack of structures. Basically, you have an area that is just sort of coagulative necrosis. What about the place where infarcts are the most feared? The heart. Okay. Well, the heart, when it gets infarcted, basically has kind of an end artery thing, so it might be pale at first. Immediately following this dead tissue is the ingrowth of neutrophils, perhaps even macrophages chewing up the dead tissue. It's already lost the nuclei. You might remember that. And ultimately, new blood vessels may grow in and it may organize and become a little pinker again. But remember, heart tissue, heart cells, heart muscle cells, cardiac muscle fibers, they do not regenerate. So if it heals, it will heal with a scar. And scars, again, are pretty white and pale, aren't they? So you're probably wondering, is this an acute infarct where there's just no blood flow there? Or is this an old infarct where it's fibrous tissue? To tell you the truth, I really don't know, but I would lean more towards an old infarct rather than a new one. But I could be wrong. Last topic of the day, shock. What is shock? Shock is a word that 90% of the time when it's used wrong, okay? Everything that happens now, oh, I was in shock. Oh, I saw a mouse. I was in shock. No, shock is circulatory collapse. Collapse of your circulatory system. It could be due to the fact that the heart ain't pumping it, or it could be due to the fact that there's no fluid in it. Or it can also be due to the fact that there are substances in certain organisms, particularly bacteria, particularly in gram-negative bacteria, but it could be other organisms as well, in which trigger off an acute early infarct or sort of a vasodilatory response where even though there's volume in it and your heart may be working okay, you don't have any resistance to your cardiac systole, so therefore your heart, for all practical purposes, is not pumping. We're going to show you what it looks like grossly and microscopically, And we're going to talk about the stages of shock as well. But remember, I guarantee you, even if you're making rounds or you're in medical school and somebody uses the word shock, 9 times out of 10, they're probably using it wrong, because shock is cardiovascular collapse. Why would your entire blood space collapse? Well, because the heart ain't pumping it, or you've lost so much fluid that there's nothing to pump. There you go again, inadequate tissue perfusion. As a result, there's cellular hypoxia. I think you could probably think of it as a early total body infarct, okay? In the early stages of shock, you have normal physiologic mechanisms, usually the catecholamine response, to try to compensate for it. If that doesn't work, then the organs start to fail, and that's more serious. And then in the final stage of shock, probably the single most important organ dies, which is your brain. So cardiogenic shock could be either acute or due to chronic congestive heart failure. The hypovolemic shock could be due to hemorrhage or loss of fluid from other reasons, okay, like extreme dehydration. And then the third, and maybe even the most common type of shock, is what we call the septic or endotoxic shock. And I've been told that it's the #1 killer in ICU, because when bacteria basically overwhelm your body and they release their endotoxins, and it's usually gram-negative ones, these endotoxins, which chemically are lipopolysaccharides, then trigger off an entire body inflammatory early response, resulting in loss of blood vessel tone and vasodilatation, and therefore you no longer have any resistance to your heart pumping, and therefore you have no flow. Oh, technically, blood vessels are also innervated through the autonomic nervous system. If there was a significant brain injury, technically, that destroyed that part of the regulatory autonomic nervous system, that could be a factor, but it's not common. And then you do hear the word anaphylactic shock, and that's the same as an acute allergic reaction in which the release of IgE causes systemic vasodilatation ultimately. And once there's significant vasodilatation and significant vascular permeability, like in an early acute inflammatory response, you then lose your vasal tone and your fluid as well. Cardiogenic shock. Why would somebody be in cardiogenic shock? Well, they had a significant MI. Maybe they ruptured their ventricle. It may be as part of that MI, or maybe another reason. Maybe there's a bullet that went through it, okay? Maybe apart from anatomic findings, there's a significant fatal arrhythmia, like, ventricular fibrillation, in which basically the heart is not pumping, but it's quivering, okay? Cardiac tamponade, external pressure, particularly in the pericardial cavity. Maybe a pericardial hemorrhage is causing compression of the heart. Or we also gave the example of a very significant pulmonary embolism, including a very, very large portion of the right heart, and therefore failure of the left heart as well, or what they call cor pulmonale. In hypovolemic shock, it could be due to hemorrhage, traumatic hemorrhage, coagulopathy. Your vascular compartment basically loses fluid or water. Patients in certain cases that have excessive vomiting can lose their body water as well. Patients with massive, extensive diarrhea can lose their body and therefore their vascular water as well. Patients with traumatic burns okay, leak fluid significantly from their vascular compartment. It can also produce hypovolemic shock. And very often you'll hear the term heat stroke. And just like I told you, when you hear the word shock, it's usually wrong. Usually when you hear the word heat stroke, technically that's not wrong either, because a stroke is a lack of blood supply to a brain. Whereas a heat stroke is basically somebody that's been exposed to extreme heat and there's been severe dehydration, and that's another way for water to leave not only the body but the vascular compartment as well. In septic shock, usually associated with overwhelming infections. The substances, it's usually bacteria, it could be fungal as well. It's usually gram-negative, but the so-called toxic shock syndrome was discovered to be due to strep, or staph, rather than gram-negatives. In septic shock, you have the release from the bacteria of substances chemically called lipopolysaccharides, because they're lipids, but they also are attached to polysaccharides. And these things attach to cells in a way that might be called super antigens. In other words, it triggers off a cytokine storm, okay? And this massive storm then results in an early inflammatory response, vasodilatation, and leaking, and whoops, guess what? I got a typo there. And ultimately, circulatory collapse. I hope this is all kind of logical. In the septic shock events, overwhelming infection, remember this is a #1 killer in the ICU. You have peripheral vasodilatation because the chain of events in the acute early inflammatory response. You have then pooling of blood because of significant vasodilatation, leakage of fluid. Now we're activating the endothelium, and bingo, what happens when you activate endothelium? You then trigger off the coagulation cascade, DIC. So this is the almost immediate association between shock and DIC. If your blood ain't flowing, then your endothelium is being damaged and you're triggering off coagulation. It's as simple as that. You could probably think of this as a total body early inflammatory response, like an infarct, but obviously it's not going to go on much further than that because you'll then be dead. Okay, the endotoxins are lipopolysaccharides. If you want to know a little bit about the biochemistry, they attach to a cell surface antigen known as CD14, and that basically what starts to trigger off the response. Now I'm going to show you something I've already mentioned a couple times before, is that if you actually measure these lipopolysaccharides starting to trigger off the so-called cytokine storm, well, here are the two main controlling cytokines. Shortly after the appearance of the lipopolysaccharides, you have a significant rise in your TNF, or TNF alpha, and your interleukin 1. And then these two guys are then directing that whole cascade of acute inflammatory changes, the other interleukins, either directly or both directly and indirectly. So once again, always think of TNF alpha and interleukin 1 as being the two early main controlling cytokines to trigger off the whole sequence of a further cytokine storm. Well, what is the linear sequence of events? I think from what we've been saying so far, it would probably be logical that with circulatory collapse, your blood pressure drops massively. You get hypotension with systemic vasodilatation. When you no longer have resistance, to your circulatory systolic and diastolic pressure changes, you then develop myocardial contractility, which is very, very significant. The heart just is not beating fully like it should. There's contraction problems. The ultimate contraction problem would be a ventricular fibrillation, wouldn't it? Which is usually regarded as a pre-terminal arrhythmia. With lack of flow, you now have diffuse endothelial activation. With diffuse endothelial activation, just like we saw with acute inflammation, you are now telling the leukocytes to not only clump and adhere, but also to leave, and almost like an early acute inflammatory response with neutrophils. Not only is there fluid leaking through these damaged septae in your alveoli, but now you have dead and dying alveoli. So it's not only leaking fluid, it's leaking cells, it's leaking proteins. Okay, it's what we might call an adult respiratory distress syndrome, to differentiate it from the newborn respiratory distress syndrome. But histologically, they look very, very similar. Now, with this diffuse endothelial activation, remember, endothelium is everywhere. You're going to have a DIC. There you go again. Septic shock, DIC. Septic shock, DIC. And at that stage, we now have vital organ failure. Central nervous system is the last, so maybe obtundance, lack of responsiveness might be the last thing completely before the patient dies. In the clinical stages or parts of this sequence of events, you might talk about the early phase as being non-progressive. That can be compensated for by normal body physiologic responses like catecholamines. In the progressive phase, more serious, but still theoretically possibly reversible, tissue acidosis, early organ failure, particularly kidneys, and then an irreversible stage. It doesn't matter what you do. The patient's a goner. Non-progressive, the big thing is the catecholamines, increasing the heart rate, the respiration increases as well, and the vital organs stay perfused. In progressive, the vital organs start to failure, okay? Hypoperfusion cannot be corrected. Patient has a low urine output. Because of inadequate tissue function, you'll develop an acidosis, lactic acidosis. Whoops, sorry. And finally, in the last stage, following the progressive stage, no matter what you do, there will be no correction. This is irreversible. And remember, we talked about life and death, or reversible damage versus irreversible damage. Well, irreversible means death. In pathology, you obviously have multiple organ failure. And remember, it could be almost like multiple organ early ischemic or infarct or inflammatory changes. So let's look at some of these things. Here's the lungs. Not only do you see that the alveoli are filled with fluid, but they're filled with protein. This is fibrin. Also, the cells leak through. That's why these lungs are not as spongy as they should be. They don't just have fluid in the alveoli or edema, but with the damage to the wall, they also have cells and fibrin as well. Here's the myocardium. Towards the bottom of the picture, you can see that the myocardial fibers still have largely nuclei, okay? But up here in the northeast and most of the middle part, these are necrotic fibers. They have no nuclei. The nuclei is dissolved. And furthermore, you now have infiltrates of inflammatory cells, like an infarct. Why? Because it is an early infarct, so to speak. Here's the kidneys. What would you think in the renal cortex needs more oxygen? The glomeruli or the tubules? Of course, the glomeruli. So the glomeruli up here look fairly normal, but look at the tubules. They lost their nuclei. They're nothing but necrotic hyalinized protein. This is what they call acute tubular necrosis. is what you see in a shock kidney that has basically progressed to the point where the tubules are now dead. Here's a glomeruli, however. If the DIC is activated, you now have deposition of fibrin everywhere. Here we have a glomerulus, and when you look at it under the microscope, you say, well, you know, it's a glomerulus, but I can see a lot of red in it, so it's probably just hyperemic. These are probably red cells. What if I said, these are not red cells? This is fibrin. And if you do a fibrin stain, which is fairly specific for fibrin, you can see that this is a glomerulus that is loaded with small capillary thrombi. Clinically, this progression that we talked about anatomically and physiologically, the real patient now will start out with hypotension. When the catecholamines kick in, he'll get a tachycardia and tachypnea to try to compensate for the hypotension. Because this is an early inflammatory vasodilatory response, at first the skin is warm. As it progresses, it gets cool. And then it gets blue because there's no oxygenation. The kidneys fail, other organs can fail. I'd say obtundance is a good word to use, meaning the patient is completely unresponsive. And that usually means CNS failure, and therefore the final stage of shock, as you're not surprised. In this case, it looks like it's the 7th linear item, is death. Okay, we're done. We'll have another webinar in a couple days. I think it's going to probably be on genetic diseases. We are not going over the 2-hour limit, which I'm very happy for. If you had made any questions during this, I'll read them during after the webinar is over. I'm going to show you a picture of the ugly guy again, and then I'm going to show you a picture of our fancy clock, and we're going to play our final song, which I can't remember what it is, but it's not a spiritual song. I think it's kind of a fun song, but let's see. Let's start it out.
The hardest thing I've ever done is keep believing there's someone in this crazy world for me. The way that people come and go through temporary lives, my chance could come and I might never know. I used to say no promises, let's keep it simple. But freedom only helps you say goodbye. It took a while for me to learn that nothing comes for free. The price I've paid is high enough for me. I know I need to be in love. I know I've wasted too much time. I know I ask perfection of a quite imperfect world. I'm fool enough to think that's what I'll find. So here I am with pockets full of good intentions, but none of them will comfort me tonight. I'm wide awake
rock on. Buzzards.